I'm going to talk about aligning incentives. Now, aligning incentives may not seem like an informatics topic, but it is, because you can build the most fabulous information system, but if the incentives are not aligned so that the users want you to do that and want to use the system, your fabulous, perfect, beautiful information system will not be used. So this is related to information infrastructure related to prevention and population health. So I have no disclosures. I think I'm going to skip the learning objectives. You can review those online and see if you learned those things at the end. But what I'm going to talk about are, first, I'm going to talk about what are the current healthcare system needs. Now, presumably none of you believe that our health system as it is perfect, and there are a few minor deficiencies which I will point out. First of all, we don't do a good job with population health and prevention, and we don't have comprehensive electronic patient records when and where needed. So I'll be discussing those problems. And then I will introduce you to this new idea called the HAPI, the Health and Prevention Promotion Initiative, which is a self-funding organization for prevention, population health, and electronic records that aligns incentives and can help achieve a learning health system. And I will talk about next steps moving in this direction. That's exciting. Timed out. Yes, of course, because no activity. So let's try again. Okay, so again, most of you, I'm sure, are familiar with the triple aim, and with credit to Don Berwick for promoting these objectives of the health system: better health, better care, lower costs. And these objectives have many challenges. Better health has to include prevention and population health, and I would argue it also needs to include consumer tools. Better care requires better decisions and also requires consumer tools. And lower cost means we have to avoid errors. And errors are not mistakes. Mistakes are when you know what to do and you just don't do it. Errors in this context are systemic problems that you may have done the best thing that you could do based on the information you had, but the system has failed in the sense that you didn't do the optimal thing because you didn't have the information you needed, for example. We need to avoid duplication, and prevention also, in many cases, can lower costs. So you can categorize these challenges, and you can do it in a number of ways, and I don't think it's worth a lot of discussion about exactly how to do it, but it clearly includes prevention and population health. It also includes having comprehensive electronic patient records. And it also includes a learning health system, and I think you could argue that the learning health system probably can impact all these problems, but in particular I highlighted better decisions as an important property of a learning health system. So these three things, prevention and population health, comprehensive electronic patient records, and a learning health system, are all necessary prerequisites for achieving the triple aim. So let's talk about prevention and population health. So first, my simple definition: improving the health outcomes of groups of individuals. And I've very diplomatically indicated that the U.S. performance measures are weak. Again, I didn't want to put anything too direct on a slide, but weak is a very kind characterization, because we spend more than twice as much as, again, most of you know, on healthcare as other industrialized nations, but our outcomes are terrible. We rank 24th of the 30 OECD countries in life expectancy, and only 3% of our spending is on prevention, even though 75% of our medical costs relate to preventable chronic conditions. So this is clearly an imbalance, and the question is, how can we do better? So the Affordable Care Act does address this in several ways. First of all, through accountable care organizations that are incentivized to increase prevention and health promotion and to improve care coordination and to achieve better outcomes. And this is very, very important. Also, the Affordable Care Act includes community and population health funding. There's a Prevention and Public Health Fund, which is supposed to now be $2 billion a year, but Congress keeps nibbling at it, but that's what was in the original bill. There are incentives for wellness programs, and every hospital now is required at least every 3 years to do a community health needs assessment. Every hospital has to look at the community and see what the health needs are. And so as a result of this, the incentives for prevention have greatly increased. And this is good, and we're going to take advantage of this. But the challenges to prevention and population health are numerous. First of all, for providers, this is a new activity. Providers don't do this. Providers take care of people one at a time and typically are not engaged in population level activities. And so in order to do this, they have to establish new programs, they have to hire new staff, establish new procedures. Now imagine a community like most communities where there are multiple competitive health systems, and this is a typical situation. So if each provider, each major system, hires a new staff, establishes new procedures, and then focuses on their quote-unquote population, which of course is not really the population, it's just the patients that they see, that's very inefficient because you have all these duplicative staffs and they're all focused on a narrow portion of the population with unknown overlaps. And it's actually more expensive when you're doing population health to narrow your focus to a specific subset. It's much easier to reach the whole community at once. And also, importantly, in this scenario where the competing organizations are all doing prevention, who's going to invest in long-term prevention? No one. Why? Because you don't know if you invest in something with your patients that's going to provide a benefit in 5 years, you don't know if those people are going to be your patients in 5 years. So you don't want to invest, and neither does the other system or the other one or the other one. So as a consequence, no one will invest in long-term initiatives. So this is not a good way to do this. So a potential solution that's been described, Steve Shortell, the former dean of the School of Public Health at UC Berkeley, has written about this. The idea of a collaborative community prevention organization. Makes sense. All the providers pool their resources for prevention, and they hire one staff, and they work on the entire population. And this is good. This makes sense. There are clearly financial and operational incentives for this. So the issues for this are, how do you fund such a thing on an ongoing basis and assure that the providers who are competitors, not necessarily friendly, cooperate with each other over the long term? You have to have initial capital and annual operational funding. And the incentives for this are good, but in my view, they're not compelling. Which means some people may do it, but a compelling incentive means lots of people will do it. And in addition, in order to do this kind of initiative, what do you need? You need comprehensive patient information. Why do you need that? Well, because you don't want to send out a reminder, for example, to people you've identified who need, say, a colonoscopy, who actually just had the colonoscopy, but you didn't know that. So that's not very helpful. So let's change our focus for a minute to the learning health system. So simplistically, what's the objective of the learning health system? It's to learn from every patient encounter. Let's get smarter as we provide care so that we can improve the care for individuals, for families, and for the entire community. and immediately apply the results of today's care to tomorrow's situation. Now, in order to do this, what do we need? Well, we have to be able to search and aggregate prior records. We need to know what has happened to patients like the one in front of me in the past. And in order to do that, we need comprehensive patient information. So, we've been working on this idea of comprehensive information since I started at HHS in 2002, and the Office of the National Coordinator was created by Presidential Executive Order in 2004. But we haven't done as much as we could. And this is a shot of an article that I published in JAMA almost a year, actually a little over a year ago, about putting health IT on the path to success. The obvious implication is we are not on the path to success. So let me talk about that. So first, whenever you do any kind of big, complicated project, it's very important to have a very clear goal statement, preferably a very simple goal statement. So what is the goal of health IT? The goal of health IT is not to achieve meaningful use. The goal of health IT is not to exchange as much medical information as possible. The goal of health IT is to assure the availability of comprehensive electronic patient records when and where needed. That's the goal. All these other things are possible means to that goal. And when I say assuring the availability of records, it's not just for individuals, but it's also in the aggregate. We need to have these records available for research, for public health, and for the learning health system. So there are two basic requirements you have to meet in order to achieve this goal. First, all the information has to be electronic. It's going to be very difficult to provide comprehensive electronic records of records that are not electronic. That doesn't work. So all providers need to use electronic health records. And actually, we've made quite a bit of progress towards this goal, but I would point out, even in the most optimistic estimates from the Office of the National Coordinator, there's still a very large number of providers who are still using paper. But more importantly, we know that patients go to multiple providers. And wherever they go to a provider, they drop a record. And so the information about each patient is scattered among multiple providers, and we have to have a mechanism to bring this information together for a patient. And this has been termed health information exchange. And this is where we're really having problems. Basically, our efforts on health information exchange are failing. So let me present you the evidence. First of all, HHS itself, through ONC and CMS, has admitted that this isn't working. And this was not widely reported, but they put out a request for information a little over a year ago, asking for ideas about how they could accelerate interoperability. And of course, interoperability is an important step on the road to making sure comprehensive records are available. And what they said was, current efforts alone will not be enough to achieve the widespread interoperability and electronic exchange of information necessary for delivery reform, where information will routinely follow the patient regardless of where they receive care. So they said, hey, we're doing all these things, but we know it's not really enough to make this happen. Now, several years earlier, the President's Council of Advisors on Science and Technology said that HIE efforts through the states will not solve the fundamental need for data to be universally accessed, integrated, and understood while also being protected. So that was more than 2 years before that. So obviously, they were cognizant of this. Your own Julia Adler-Milstein has been doing surveys of HIEs periodically, and in the survey she published in May 2011, she looked at 179 HIEs. And at that time, only 13 met meaningful use stage 1, which in no way assures comprehensive records. And this is, represents 3% of hospitals and 0.9% of physicians. And of those 13, only 6 self-reported as sustainable. And that's with no audits. And so, and finally, none, 0 among those 179 met an expert panel definition of a comprehensive system. Presumably a comprehensive system would be one that delivered comprehensive records for each person. And so this called into question whether RIOs, or Regional Health Information Organizations, in their current form can be self-sustaining and effective, and that's a quote from the abstract. And I will say she's published a survey since then, and the situation has not improved significantly. As you would expect from this, multiple HIEs have already failed, and I would specifically direct your attention to CareSpark in Kingsport, Tennessee. CareSpark was touted as a national leader for years. They were, they were giving talks at all the meetings saying, we're on the forefront, we're doing all these good things, and then they shut it down because they had no business model. And so as a consequence of all this, no patients in this country, none, currently receive their care with guaranteed availability of comprehensive records from all sources. 0, which is the same number that received their care with guaranteed availability of comprehensive records when I went to HHS in 2002, now 12 years ago. That's not to say there's been no progress, but this is the goal. So the question is, why are the HIEs failing? It's not because of lack of money. This is often a problem, particularly in public health. But the federal government allocated $564 million to this in March 2010. And even in Washington, D.C., where I'm at, $564 million is, not round-off error. That's a lot of money. And the challenges are well known. I mean, the issues are privacy, stakeholder cooperation, and sustainability. People know what the challenges are. So why are we failing? We're failing because we're on the wrong road. We're trying to replicate the manual process of contacting providers for records. So from an individual physician's point of view, how does this problem manifest itself? Mary Smith comes into my office and says, I've seen Dr. Jones down the street, and I have my assistant contact Dr. Jones, fax the records over so I can see what happened when Mary Smith saw Dr. Jones. So let me see if I can use this pointer. Does this work? No. I won't point it at you to see. Let me see.
Pointers work and use also nobody's job description.
Yes, okay, here we go. I'll use this pointer. So the way this works is, oops, the clinician requests information from the HIE, and the HIE has an index of where patients have been before, sends out secondary queries to all these other EHRs, waits for them to all respond. Then all those records need to be assembled in real time, and of course any contradictions need to be resolved. And then the assembled record is sent to the clinician. The patient encounter occurs, the data is stored in the clinician's EHR. So this is essentially replicating how we do it now. So what's wrong with that? Well, quite a few things, it turns out. First of all, it's complex and it's expensive. All those EHRs that are being queried, they all have to be available 24/7. It's okay to respond to queries. You need to do this real-time reconciliation of records, and that's really, really hard. And in order to do this right, it really requires a unique patient identifier, because otherwise you can't be sure whose record goes with who in real time. And not only is this politically impractical, I will remind you that The HIPAA legislation in 1996 included provisions for a national unique identifier, and there were hearings in the House and hearings in the Senate, and both chambers voted for it, the president signed it, and then people found out about it and it was gone in 30 days. And let me say also, what percentage of Americans do you think contacted their congresspersons to complain about this? Was it 10%? Was it 50%? No. Was it 10%? 1%? 0.1%? Very small number. But they were very vociferous, and Congress eliminated it. So this is politically impractical. This is not going to happen. It's also a privacy threat, because you do not want to have a persistent single number from birth to death for your medical records. In addition, in order to make this work, you have to have a network operations center to monitoring all these EHRs to make sure they're online. And the cost of that operations center is staggering. So another problem is the more of these data sources you have, the more likely you are to have errors. And this is just simple math. So assume all your data sources have some small probability of failure. Well, if you have one data source that has a 1% probability of failure, what happens when you have 10 data sources? Is your probability of failure still 1%? No, it's additive. The probability of failure of one of those data sources, which means you have an incomplete record, goes up. And that's what this graph shows. The more data sources you have, the more the errors go up. This is the other graph here is for a central model. You also have increased liability. So patients can't review or annotate the data in this situation, and the providers in the HIE are responsible for whether it's correct, and it's not easy to propagate corrections. This is a key point. This is not financially sustainable. And here's why. Think about the value of health information versus completeness. So let me paint a picture for you. Imagine there were an information system in our country where any authorized physician could query the system and get 50% of the medication list for any person immediately. 50%. What would the usage be of such a system? Zero. Zero. Why? Well, because getting half the medication list has zero value. In fact, it has negative value because the time that you spend getting that 50% is not valuable because you're going to have to ask the patient anyway. So what we're talking about is operating here at the 50% level, where the information is 50% complete, has no value. This is what I learned from doing the immunization registry. If you do an immunization registry and make it available and tell everybody, well, we've got half the records for all the kids, it's useless. Until you have 85+% of the records reliably, it has no value. So you have to take this into account when you're building these information systems. If you want something with value, the records have to be relatively complete. You can't protect privacy in a system like this because there's no single place for consumers to indicate their privacy preferences. If you leave the data where it is, essentially the patient's responsibility, even if you allowed it, would be to go to each provider and set their privacy preferences and keep them all updated. That's not going to happen. Importantly, in this scenario, you can't ensure that the stakeholders are going to provide those records. In other words, when you do those queries, first of all, the stakeholder is going to allow you to do the queries. Are they going to give you the information? And because the stakeholder participation in an HIE set up this way is voluntary. Voluntary. And so even if you get them to cooperate, they might not continue to cooperate. The only way you get stakeholders to provide records reliably is to force them. And the way you force them is the patient requests the information. And under HIPAA, it has to be provided, and it has to be provided in electronic form. You can't search the data when you do it this way. Why not? Well, because you don't know what the data is. So the way you search it is, you say, okay, I want everybody in the Detroit area with a cholesterol over 300 because I want to intervene. How do you find that? Well, you start with record 1, you send out the secondary queries, you assemble the record, you look to see if there's a cholesterol over 300. And then you do it for record 2, record 3. In computer science, we call this a sequential search. And we don't do sequential searches in computer science because we like our searches to finish before we die. A search like this with, with any reasonable size database would take, days, weeks, long time. And you'd have to do it every time you search the database. And so this just isn't practical. And so you can't support care reminders. You can't support research and policy, and you can't support a learning health system. I mean, it's not going to help me if I have a patient in front of me and I can do a query and get the results 2 weeks from now. That's not going to help me. So what are the consequences for stakeholders of this? Well, for health plans and insurers, they're facing continually escalating costs and no comprehensive patient records. Hospitals have inadequate and incomplete patient information on admission and in the emergency room. They also have uncontrollable financial risks, for example, from readmissions, ineffective and inefficient prevention activities. Physicians experience adopting EHRs and essentially just electronifying their existing silo. Doesn't really help them get complete records so they can provide better care, and they also can't do good prevention. And patients are the worst off because they suffer from preventable errors and adverse events, unnecessary repeated tests and procedures, and continually escalating costs. And finally, the government and the community also have to deal with the costs, ineffective and underfunded prevention, and data unavailable for policy research and for a learning health system. But we have choices in HIT architecture, or I guess in HIE architecture. As I explained, this distributed architecture, which has been tried over and over again, just doesn't work. The idea of leaving the information in place and retrieving in real time is inefficient, error-prone, doesn't scale. It's hard to protect privacy, and you can't search the data. But there's an alternative. A centralized architecture, or what I call a health record bank, what ONC is calling consumer-mediated health information exchange. So a health record bank is a secure, community-based repository of complete health records with access to records completely controlled by the patients or whoever they designate. Think of it as electronic safety deposit boxes or a checking account for your medical records. The information about care is deposited once when it's created. That's required by HIPAA if you ask for it. And you can build a business model that allows EHR incentives to physicians on an ongoing basis so that essentially you relieve physicians of most of the cost of electronic records over time. And this is simple and inexpensive to operate. So I have a short video to show you about this.
Imagine you or someone you care for is rushed to the emergency room and might even be unconscious. Without important medical history, lives may be in danger. Does the emergency room doctor have all of your up-to-date personal health information? Do you? How can you or your doctor get it immediately? If you're like most people, your medical records aren't readily available to you or any doctor. Today, wherever you seek care, a record is left behind. A record you and your other doctors can't immediately access. Until now, no institution has been available to automatically receive and securely store your records and make them easily available when and where you need them. Now there's a way with health record banks, a secure approach to storage where you alone control access to your health information. Think of it like a digital safe deposit box. When seeking care or in an emergency, you authorize an information withdrawal, giving your doctor access to some or all of your records. When care is complete, new records are deposited, and the information can be used to automatically complete time-consuming forms. Health record banks make good sense. You alone control who accesses your personal, private health records. Records are stored in one location and automatically updated when you receive care, anywhere in the world. Your information is safeguarded by the most secure data protection and encryption methods. And with multiple banks available, the choice is yours. Take control of your health records today. This message brought to you by the nonprofit Health Record Banking Alliance, promoting and supporting the development of health record banks.
So the architecture of a health record bank, unlike the other architecture I showed you, is very, very simple. The clinician requests the patient records from the health record bank, gets them, patient encounter occurs, new records are deposited. As simple as could be. The rationale for this is the records are immediately available, new records are deposited when they're created. Because you have the records, you can do value-added services, and I'll talk about that in a minute, and you can do research queries, so you can search. Patient control enables trust and privacy and forces stakeholder cooperation. The low cost of this, and it is low cost, facilitates the business model, and you can create EHR incentives options by either paying for deposits of information or just providing internet accessible EHRs to docs on an ongoing basis. So how do health record banks create value? So if you have a health record bank that includes free or subsidized EHRs for physicians, you get more complete electronic health record information. I think you'd agree that if EHRs are free or subsidized on an ongoing basis for physicians instead of temporarily, there will be higher levels of adoption. And so then you get free benefits to physicians and patients from that information. The patients will sign up for the health record bank as recommended by their physicians. So you ask the physicians to recommend this to their patients, and there's no cost for sign up. But then the patients choose compelling value optional services. And I'm going to talk about what those are in a minute. And they're so compelling that patients will pay a little bit for them, some patients, and that generates money that allows you to operate the health record bank, and actually more than that, as we'll see. So let me talk about the business model. So assume you have 1 million subscribers. The cost to operate a health record bank is about $6 per person per year, $6 million. You can run a fine health record bank, probably less. The cost of EHR incentives for providing essentially free internet accessible EHRs to docs or to pay docs the equivalent in cash is about $10 per person per year. So your costs are about $16 per person per year. So set that aside for a minute. Where is the revenue? Well, first of all, there's advertising to consumers. You can earn about $3 per person per year from advertising. You, I think, need to provide an option to opt out. So you'd say to consumers, just like Hotmail used to be, want no ads, pay a couple of dollars a year. The key source of revenue, though, are for reminders and alerts. And there are 3 types of reminders that I've identified, but there are lots more possible. The most compelling is what I call the peace of mind alert. And the way this works is, if an emergency doc accesses your records, meaning you're in the emergency room, your loved ones are immediately notified electronically. Everyone I talk to who has disposable income is willing to pay a little bit for this. And so let me just give you my typical price point for this is $20 a year. For $20 a year, everybody wants this. Preventive care reminders. So this would be based on your demographics and your record. You would get customized reminders about what you needed to do to maintain your health. Not everyone will pay for this. Actually, third-party payers should pay for it, but some people will pay for it. And then medication reminders, primarily refill reminders, because only about 70% of chronic medications are refilled. So there's a big gap. And so you would essentially get a text message every month saying, time to refill your Lipitor, would you like us to do this for you? You text back why, send, and we take care of it. And the great thing about medication reminders is that would be free to consumers for brand name drugs because pharma would be happy to pay for it. So if you think about each of these as a $20 a year opportunity, based on not having everyone sign up. If everyone signed up for it, you would earn $60 per person per year. So I've estimated, based on much lower penetration than that, $18 per person per year. And finally, research queries into the database, which you would charge something for, you can make at least $3 per person per year for that, and still have very, very low charges for fabulously valuable queries into the database. So 18 and 6 is 24 most days, and 24 is a lot more than 16 the cost, and you have a profitable business. And I want to direct your attention to one important characteristic of this business model that I haven't said anything about healthcare savings. I didn't say this was going to save money. So this business model does not care about healthcare savings. Of course, we all care about it. But this business model does not depend on healthcare savings, on identifying them, capturing them, allocating them, nothing. Any healthcare savings go to whoever saves the money. So here's an example of how this works in practice. Modeled on Houston, with the Houston metropolitan area has 5.7 million population. And so with initial capital of 4.4 million, you break even in 16 months, and you're, for those of you not in the business world, EBITDA, earnings before income taxes, depreciation and amortization, essentially is your gross profit, is over $41 million a year in year 4. And that's assuming 50% penetration in the population. If you get up to 80 or 90%, your profits would be even higher. Interestingly, if you look at the net budget of the Houston Department of Health and Human Services, and this is, you'll see why this is important in a minute, it's $35 million, or excuse me, $32 million a year. So this generates enough money to pay the entire budget of the Houston Department of Health and Human Services and more. And that leads me to HAPI, the Health and Prevention Promotion Initiative. And so if you combine this community prevention organization with a health record bank, what happens? Well, the health record bank gives you the needed information, ensures the records are electronic, it generates revenue, and not just revenue to pay for the health record bank. It generates a lot of excess revenue, and so it can provide funds not only for itself, but to pay for all the prevention and population health you want. And it supports a learning health system. So how do the incentives work in this? So with patient control and a central repository, you protect privacy, and that enables you to have a central repository, and that data empowers prevention, which is a stakeholder need. And patient control also ensures stakeholder cooperation because of HIPAA, and that provides you with the electronic patient data you need to get the benefits. Clinical benefits of improved quality and decreased costs, reminders and alerts, research, and a learning health system. And the revenue from the reminders and alerts and the research pays for the prevention. And it also can provide financial incentives back to the physicians for electronic records and to the other stakeholders to reinforce their cooperation. Now, that's a nice steady state, but how do you get to this lovely steady state? So the way you do this is you start with the physicians, and you go to the physicians and say, Doc, would you like a free or subsidized electronic health record? And of course the response is, what's the catch? So 2 things. 1, we want you to deposit the information from each encounter into the health record bank. You have to do that anyway under HIPAA. Okay, no problem. Second, we want you to make it your policy in your office that everyone has to have a free health record bank account. So essentially what we want you to do is hand each patient an enrollment form at the registration area and tell them they have to sign up. Costs them nothing, and they control the information. And we know from other similar programs that over 90% of people will sign up the first time when you do this. then the physicians recruit the patients for the health record bank accounts, and then you offer the optional services, the reminders and alerts to the patients, and that's how you generate revenue. All the stakeholders benefit from this in a big way. The health plans and insurers get lower care costs through better information, prevention to lower future costs, and interestingly, if you think about this, if you just capitalize it once, then it pays for itself. That's a big benefit. Hospitals get prevention services, better information and tools for care. They'll get a patient portal, which they need. And again, it's sustainable after an initial investment. Physicians get free or subsidized EHRs, free if they don't have one, subsidized if they do have one already, because we don't want to replace them. And better information and tools for care and prevention services, which they need. Patients get better care, tools for health and prevention, control over their own records that facilitates privacy, and they get free basic accounts. And the government and the community benefits from lower costs, prevention, and information for policy, research, and the learning health system. And not just information, but comprehensive and timely information. So let's go back to the triple aim. You remember these challenges and the prevention and population health, comprehensive records, and the learning health system. And we can address all these things with this HAPI approach. So the next steps are to implement HAPI pilots. And so I'm now looking for candidate communities and outside funding to reduce the risk, disseminate the lessons learned, and organize HAPI projects in multiple communities. So in summary, prevention and population health are now essential. And health record banks can provide the comprehensive electronic patient records that are needed to do this, including incentives for EHR adoption and excess revenue. And then, if you combine this community prevention organization with a health record bank to get this Health and Prevention Promotion Initiative, or HAPI, you can successfully pursue the triple aim and support a learning health system. Thanks for your attention. Happy to take your questions. Questions? Yes, sir.
It's a wonderful presentation. You present a very compelling case for the health record data bank. The question, a couple of questions and thoughts. You also raised quite a few questions in my mind. The first question is that what will be the governance structure for the health record data bank? Now, if it's still a government-run agency, and it seems that you can stay away from asking patients to have a unique identifier in order to link all the data to create a safe deposit box for every patient, then the HIPAA law will still apply. How do you sidestep that issue? So that's one.
Okay, let me come back to you so I don't have to remember all your questions. I'll let you do that. Okay, so there are two questions there, three questions already. One is, what's the organization? Two is, how do you do the identifier, and how do you deal with HIPAA? So let me get those three. So in terms of how this is organized, the real answer is no one really knows how to best organize this, but I can tell you some ways not to organize it. It cannot be run by the government. That just won't work. First of all, people don't trust the government, but second of all, the government really needs to regulate these things. And so if it's going to regulate them, it can't also be it's not going to, regulating itself is not good. So it can't be the government. My belief is that the way to do this is with a new nonprofit organization in the community. And then that organization can hire a for-profit organization to actually build and operate the health record bank. And then the not-for-profit can essentially regulate the for-profit through its contract. And the for-profit would pay a fee to the not-for-profit to cover their expenses. That's my belief, but this is the organization of this is a very complicated issue. So I want to make it clear that's my belief, but we don't know. The second question is identification. That I can answer clearly. The way health record banks would do identification is the same way we do identification with credit cards. So each health record bank would issue cards, and hopefully they would all issue cards in the same format, like credit cards, and they would each have their own part of the number space. So you would have a card in your wallet with your health, essentially your health record bank card. And if that card were lost, it would be the number would be invalidated, and you would just get a new card. And then when the information comes into the health record bank, if it had your number on it, it would immediately go in your account. If it didn't, you were going to a new provider, we would then create a table for you associating the identification number that that provider uses for you with your internal account number. And that might require a human being to intervene the first time, but then anything else that came in from that provider would automatically go into your account. This is one of the great things about health record banks. You don't have to do the identification in real time without any human beings involved. You do the identification, and if there's any discrepancy, you have human beings look at it before the deposit is made. Okay, HIPAA. A health record bank is not a HIPAA-covered entity by definition, because, of course, when HIPAA was passed, there was no concept of a health record bank. A health record bank could become a HIPAA-covered entity if it entered into business associate agreements with providers, which it might do. But regardless, makes no difference, because everything a health record bank does is by consent of the patient. And as long as you have the consent of the patient, you pretty much cannot violate HIPAA. So it's not really an issue. So next question. Let me let him get his other question, and I'll get to you.
Well, in a way, if gladly you could clarify the 3 points. In a way, we have a model. Even it's a model run by the government. The VA has a data coordination bank sitting in Austin, Texas, that has provided the infrastructure they just described, almost to the T, right? So why is it that we haven't been able to learn from a system that is within our house? What is the political problem here? That's the second question. The third question has to do with your happiness model. Now, I'm from Taiwan, and I travel back to Taiwan quite often, and every citizen in Taiwan has a health insurance card, and they have built a national data health record bank. But they haven't been able to reach the happiness state. I'm wondering why.
So I can't answer the last question, but I'm intrigued by that because actually there are other countries who have done that too. Estonia is one. And this is one of the areas that I'm very interested in because I'd like to find out more about that. So remind me your previous question was?
The VA model.
The VA. So the VA model, first of all, there's some problems with the VA model. As I understand it, the VA system is essentially islands of information. So if you go to multiple VAs, there's no unified record. But they may have fixed that. But the real question was, why haven't we learned from that? And this is what the happiness model is supposed to address. The health record bank alone has huge benefits for patients and for physicians. But the other healthcare organizations are either neutral or they're suspicious or they're hostile to the idea. They feel like this is going to create a loss of informational advantage for them. But in the happiness model, essentially what that does is it takes the profits from the health record bank and gives them back to the healthcare stakeholders. It doesn't give it back as money, gives it back as population health services. But it's as good as money, and the financial incentive for them to do this is very, very high. And so my expectation is that, and that's why I titled the talk Aligning Incentives, that this model really does align the incentives. And it's not that we haven't learned from these other models. We know these things are true, but we haven't applied them because the incentives haven't been aligned. So that's thank you for bringing that up. In the back.
So it seems like patient engagement is a central element to making your business model. And I wonder how much data or experience you have that this is actually saleable to patients, and particularly patients who are the sickest with multiple conditions, chronic conditions,
Right.
that you really need to buy in.
So first of all, patient engagement is it depends how you define it. So first I would say yes and no to patient engagement. If you sign, first, let me talk about patient engagement. The idea, because we want everyone to have a health record bank account. And thankfully, the vast majority of people are not sick. And it's a good thing because our healthcare system couldn't handle that. So not only do you want, if you say, well, all the people with health record bank accounts have to be actively engaged, you're not only saying that people who are sick have to be engaged, but everybody has to be engaged. That's not going to happen. Most people could care less about their medical records, and if they're not sick, they certainly are not interested. The good news is that to benefit from a health record bank account, you don't have to engage at all. You just sign up, say you want the default consents, which basically would be all your providers get to see all your information, and that's it. So while I believe patient engagement is important and can be very valuable, it's not a requirement to make the health record bank successful. But what is required, which I wouldn't call patient engagement, but I would call purchasing apps, is some of the patients have to buy these apps. And again, the apps, for example, the Peace of Mind app, you just purchase that and then you don't have to be engaged. You just have that, it's peace of mind, and people will buy that even if they never get an alert. In fact, they hope they never get an alert that their loved ones are in emergency care. The evidence for that is we have done some market research on that, and in a survey, a substantial proportion of consumers said they would pay $50 or $100 a year for reminders. I think it was 20% in a market research survey. So we have tested, at least with market research, the demand for this kind of an app, and it really is there. But that's why when I built the business model, I made the assumption, I didn't assume that, even though I think it's appealing to everyone, I didn't make the assumption that everyone was going to get it. Let me say also that in terms of apps, I gave you 3 examples, but I'm sure you know there's a whole Health 2.0 community that's developing thousands or maybe even tens of thousands of clever health apps, none of which are widely used. Why is that? Is it because the ideas aren't good? No. Some of the ideas are very good. The reason they're not used is because the most interesting apps require you to enter your medical information and keep it up to date, and that's too much work. So in a health record bank, you would have the equivalent of an app store where you would invite the whole Health 2.0 community to come in and deploy apps and encourage consumers to sign up for those. Some of them would have fees, and the health record bank would collect some of those fees. So you would be able to engage this whole community in creating value with this information. Yes?
Where does, in the model for the health record bank, where does reconciliation of different data coming from different sources and not agree, where does that take place?
So it could be, that could be handled in a number of different ways. I think that one way that can happen is from the patient. So if we can get the patients to look at their data, just like you hopefully, or some people look at their checking account statements every month to make sure everything is in order. I'm not sure that's very valuable because there are not very many errors, but health records do have a lot of errors. And so patients can spot errors, and we would need to correct those. I think providers will spot errors when they see things that are contradictory, and we need to provide a mechanism for them to let us know, and then we will mark those. So the interesting thing about reconciliation is we don't know a lot about that because we don't have any source of comprehensive records now, so we can't see the errors that we need to correct. So I would argue that shining light on all those errors is a good thing, and then obviously we're going to have to implement some good mechanisms to deal with that. But I would rather have the situation where I show the physician all the records from all the different sources, even if they don't agree, then the physician is essentially uninformed about all those records. Thank you.